So this is the explanation of the lithotomy position, which is quite commonly encountered in general surgery for sort of rectal procedures, hemorrhoids, that kind of thing, and also lots of gynae procedures. So be prepared for that one, and you can ask about it at the team brief at the start of the list. It involves your patient being supine on the table like Sid is demonstrating for us, but then the legs being lifted into these stirrups which are attached to the side of the bed separately, and that should be the responsibility of the scrub staff, but it's worth knowing how to do it yourself. Sid and I have just learned, so we can try and teach you some other time. So important things anaesthetically to know are that it's on your request that the legs go up into the stirrups in the first place. So check you're happy with your airway. You don't want anybody moving in a patient when you're worried that they're light and any risk of laryngospasm. So it will be on your request, and the scrub staff will look to you to lift the legs up. They'll do them both at the same time, and you just want to check that the patient's legs look sort of anatomically and physiologically correct. So no overextension at the hip joints, knee joints. Ankles look comfortable, the legs are not too far splayed from the midline, and you're not stretching any nerves as they pass down the leg. So that's up to you to check. You'll also find that when the legs go up, you get a big increase in venous return, so you may find your blood pressure monitor records a higher reading temporarily. And also, if you have a larger body habitus patient, you may find that the act of putting the legs up also makes it harder to ventilate them. So one to preempt if you have an obese patient, just to think about at the beginning your choice of airway. If you think you might struggle to ventilate when the legs go up, just worth noting beforehand, and you can put a tube in rather than an LMA. Same thing applies at the end of the case. The legs will come down on your request, so be prepared that you'll lose that venous return that you got when you lifted the legs up. So you may find a dip in your blood pressure, and that's just physiological to be expected, and you can preempt it and correct it with fluid administration during. Okay, next position to show you is Trendelenburg position, or head down. So this is most commonly during laparoscopy, so you might get your surgeon requesting, in fact, all sorts of table movements during that to facilitate their view, but most commonly head down. So this one, you use your remote here, and you see this orange button that helpfully says trend, that means Trendelenburg, and you press it, and you're going to see Sid, press it and hold it, going head down. So anaesthetic considerations for this one, a bit similar to lithotomy. You'll get an increase in venous return, as you can see, his head's now lower than his feet. You'll get increased difficulty ventilating, especially in the obese patient, and especially with a big tight abdomen during laparoscopy. And you'll find that staying in this position for a very long time can cause a rise in ICP, rise in swelling in the conjunctiva, and you might see that quite commonly and quite pronounced at the end of a long case. So worth thinking about any patients with intracranial presentations or raised intraocular pressure. And if you're really there for a super long time, like some long robotic cases, you can even get laryngeal swelling, and that's worth just thinking about before you extubate your patients at the end. So that was the orange button that gives you head down, and then to correct it, you can either do the reverse, which is this button here, or just level again, and if you hold level, you'll always get back to the middle. Right, third position is the left lateral tilt, and most commonly you'll come across that in obstetrics, where you're going to roll your patients 15 degrees to the left, and that's to remove the weight of the gravid uterus from compressing the inferior vena cava. You'll find that the physiology is really pronounced in pregnancy, and you can actually cause complete loss of venous return and even arrest by lying a pregnant woman flat on her back. So this one's pretty important. So on the buttons here, just under Trendelenburg is tilt, and you've got tilt left and you've got tilt right on the screen. So you're going to tilt the table 15 degrees to the left, which you can't really measure, but make sure your patient is aware that you're going to do that, because in obstetrics your patients are awake. Tell them why you're doing it and tell them that they won't fall. And you make sure you've got in place your arm supports and leg strap to make sure the patient doesn't roll off to the side. Physiologically, not that much other than removing the pressure off the IVC to worry about, but this is one that you may be requested to do as part of laparoscopy as well. So just remembering to keep your patient strapped and on an anti-slip mattress underneath them. So this position that Sid is modelling is called beach chair. And this is most commonly encountered in orthopedics for shoulder surgery, and it is quite an unusual one and does have quite a few anaesthetic implications, so we'll go through those in turn. The way you get here is looking at your remote control again, and there's a button here that says beach, and that's beach chair, you just hold it down, but it takes a good 20-30 seconds to get into this final position, and it kind of does it in little stages, so don't be afraid, just keep holding and you'll get there eventually. So anaesthetic things to think about for this are, your patient is sat upright, so venous pooling is going to be down in their bottom and into their legs, which means you'll lose your blood pressure quite quickly, and also you find if you're measuring your blood pressure at the level of the heart, which is where your blood pressure non-invasive cuffs are, you have to take into account that the perfusion of your brain is another sort of 20 centimetres higher, so you're under-reading the cerebral perfusion pressure when you look at your non-invasive on the arm. Because the head and upper body are at a higher position than the heart, there is quite a high chance of, if you open a venous plexus, either surgically or by putting a line in, you suck air into the right side of the circulatory system and into the right heart, and that's called a venous air embolism, and is a bit of an anaesthetic emergency. So this is one of the key positions to be thinking about that. And you'll find your surgeons commonly flooding the surgical area that they're working in with saline to try and avoid air dripping in via the open venous sinuses whilst they're operating. You would see that on your anaesthetic monitoring as sort of cardiovascular collapse and a very quick loss of CO2 and ventilation. So that is one to be aware of, that occurs rapidly and is a bit of an emergency. So prevention better than treatment. Other things to think about are that your surgeons are going to be right up near the patient's airway. So this is one way you properly secure the airway to the patient's face, and it's usually a flexible endotracheal tube, because you will not have access to the patient's airway once the surgeons have started. And you also find that there's all sorts of elbows and hands going right near the patient's eyes, and precious bits of dentition and soft neck tissue. So these, we pad the eyes very carefully and thoroughly so that we try and avoid any harm caused by surgeons to the head and neck. Other things to think about are, this is usually quite medium operation, so the patient sits in this position for a while and might start getting uncomfortable. So we pad underneath the knees and we pad underneath the ankles to make sure we've got knees and joints in an anatomical position, and therefore minimising the risk of any nerve damage and neuropraxia. Anything else to add for that one, Sid?
Or you can just put pillows in.
Or you can just put pillows, you're absolutely right. So I think those are the key considerations anaesthetically for that, and that will do for this beach position. Last position is the reverse Trendelenburg, which means head up relative to the rest of the body. So this one might be called for in some laparoscopy, sometimes gallbladder surgery, and any surgeon might ask for a slight change of position, so worth knowing how to do it. So buttons wise, we have the Trendelenburg, which is the head down orange button on the left, and opposite that is reverse, R-E-V, reverse Trendelenburg. So you press your button and hold it, same with all the other ones, and you'll see Sid's head slowly rising. So important things to note here are, again, making sure your patient is strapped closely to the table and it's an anti-slip mattress underneath, because falling down off the table is obviously a disaster for very many reasons. Same again if you have decreased pressure in the upper limbs and the head compared to the heart and the lower limbs, you run the risk of entraining air via any open venous sinuses or central lines and stuff. So worth just thinking about and being aware, looking at your monitoring at all times. And blood pooling in the lower limbs, you might get ankle swelling at the end of this operation, and find that when you level them off, you get quite an increase in venous return and a sort of temporary rise in blood pressure to go with it. But relatively straightforward position and easy to do using the buttons that we showed you. Your responsibility to attach, but Sid and I have just learned how to do them, so we can show you if we end up in theatre together one time. Wow!